All right, guys, welcome back to Underground Science. In this video, we'll be talking about disseminated intravascular coagulation, also called DIC. All right, so let's go and get started. So DIC is a widespread activation of the coagulation cascade. All right, so if you activate the coagulation cascade in a great manner, right? If you activate the coagulation cascade in a great manner, you're going to get a lot of clot formation. Okay, so you're going to get a lot of microthrombi formation, okay, in your blood vessels because you're activating the coagulation cascade. Okay, widespread activation. And of course, this has many causes, which we'll go over in a bit. But whatever the cause is, you get a widespread activation of your coagulation cascade. So you make a lot of clots inside your blood vessels. Okay. And if you're making a lot of microthrombi, right, a lot of clots, then you're going to consume platelets, right? Because these clots, in order to form these clots, you're using a platelets because that's what platelets do. They make clots. They make platelet plugs, right? So you're consuming a lot of platelets to make these clots. And on top of that, we just said it's widespread activation of the coagulation cascade. So by definition, right, you would be using a lot of coagulation factors. So if you're consuming platelets, which are important for clots, right, and you're consuming coagulation factors in those clots that you're making, then that means you're consuming your coagulation factors, you're consuming your platelets. So if you're consuming things that help you clot, then you're going to start bleeding, right? Because it's kind of paradoxical. That's why DIC is kind of weird in that way, right? So you're making a lot of clots, right? Widespread activation of your coagulation cascade. So you're making a bunch of clots, but at the same time, in order to make those clots, you're consuming a lot of your platelets and coagulation factors. So you're making a lot of clots, but when it comes time to actually stop bleeding, you can't stop it, right? That bleeding can't stop because you're using your platelets and you're using your coagulation factors. So yes, you are making a lot of clots, but that also puts you at an increased risk of bleeding. And that's what we see in DIC. Okay. So once again, you see bleeding because you're consuming platelets and you're consuming coagulation factors in DIC. Okay. So you're making a bunch of clots, but in order to make all those clots, you're decreasing your platelet count and your coagulation factor count because you're consuming them to make the clots, right? So that's going to lead to bleeding because now you don't have enough platelets or enough coagulation factors to properly seal any blood vessel damage. Okay, so you start bleeding a lot. So there's many causes, okay, and a mnemonic that helps me out is stop making new thrombi, okay, because you're making a bunch of thrombi, right, in DIC. So this mnemonic helps me out. It's like, okay, well, stop making new thrombi. All right. And we'll see how this mnemonic helps. So the S, right, is for sepsis. That's one cause. So especially gram-negative sepsis, right? When gram-negative bacteria, remember, they have certain endotoxins that they can release. So when these gram-negative bacteria release these endotoxins, they activate monocytes. Okay, remember, when monocytes go into your tissues, they become macrophages. So these endotoxins from the gram-negative bacteria can activate your monocytes, and then your monocytes can release tissue factor. Remember, what is tissue factor? Factor 3, right? Remember what factor 3 does? It binds with factor 7, and both of them can go on and participate in the common pathway by activating factor 10. So if you're releasing a lot of tissue factor, then you're going to activate your extrinsic pathway, right? So your extrinsic coagulation pathway, remember, which is factor 3. What coagulation factors are involved in the extrinsic pathway? Factor 3, factor 7, and then they go on to converge into the common pathway, which is factor 10, right? So, so again, the endotoxins from the gram-negative bacteria, okay, activate your monocytes, which is in your bloodstream. Then your monocytes can release a lot of tissue factor, which will then activate your extrinsic coagulation pathway, leading to fibrin formation and clot formation, okay? So that's one way you start forming a lot of clots. Now, in sepsis, we know that we're producing a bunch of cytokines, right, due to all the inflammation. Some of those cytokines being interleukin 1 and tumor necrotic factor alpha. So cytokines in general can also stimulate your monocytes. And then After that stimulation, your monocytes can release a lot of tissue factor, which again will activate the extrinsic pathway, and you make more and more fibrin, right? Because the extrinsic pathway converges with the common pathway, and we know the common pathway goes from factor 10 to 5 to 2 to fibrinogen to fibrin conversion, right? So we get a lot of fibrinogen to fibrin conversion. So yes, we are making a lot of clots, right? Because the fibrin, remember the fibrin mesh is important for making a strong platelet plug or a strong clot. So yes, we are making a lot of fibrin, but see what's also happening is you're consuming a lot of fibrinogen. So it's going to come into play later when we talk about labs. So one important finding in DIC is low fibrinogen levels because you're consuming so much of it to make fibrin, right? So that's happening. Okay, so sepsis makes sense of why that could trigger DIC, right? Or why that could lead to DIC because of all the endotoxins being released and all the cytokines being released can lead to activation of your coagulation cascade. All right. And if you activate your coagulation cascade, you make fibrin, which is important for making strong, important for stabilizing your platelet plugs, right? Your platelet plug that you got from primary hemostasis. So you make a strong clot instead of a weak one. Next, trauma. Okay, so remember, stop making new thrombi are mnemonic. So the T in stop is for trauma. When you damage your endothelial tissue, remember they can release tissue factor. Again, that's factor 3. Okay, so from trauma, you damage your endothelial tissue, which leads to the release of tissue factor, and then of course, right, tissue factor does what? Activates factor 7, and then both of them, right, together converge to the common pathway and activate factor 10, and then eventually, right, you make fibrin, right? You convert fibrinogen into fibrin, which will help stabilize and create that fibrin mesh on the platelet plug, right, from primary hemostasis. So that's how trauma, right, can play a role in leading to DIC. So the O now in the stop mnemonic or stop making new thrombi mnemonic is stands for obstetric. Okay. So you can get so what things, right, in terms of when we're talking about obstetric, right? What things can lead to DIC? So placental abruption can lead to DIC. So remember, placental abruption is when you have your placenta, right? And it basically detaches from the uterine wall, right? From the decidua. So you have your, let's say if you have your placenta here, right? If we draw the placenta like this, so let's say this is the placenta, and then you have your uterus wall right here, right? Okay, and then what placental abruption is, right? Placental abruption is when the placenta detaches, okay, from the uterine wall. Okay, so you get a detachment, and that can lead to a lot of bleeding. All right. And so, of course, in this, right, if if your placenta, right, abrupts, right, or gets detached from the uterine wall, then of course that's going to lead to a lot of bleeding and hemorrhage, right? But that's going to obviously lead to a lot of trauma to the not only to the placenta, but also to the uterine wall. So all that hemorrhage and trauma, we said, releases what, right? It leads to the release of tissue factor. So because of a placental abruption, this can lead to a large release of tissue factor, which is factor 3. And then of course from there we already know what happens. You activate factor 7, and then factor 7, right, activates factor 10. Okay, and then you carry out the rest of the common pathway, and then you make a lot of fibrin. Okay, so again you get widespread activation of the coagulation cascade, leading to a lot of clots. Okay, so that's how placental abruption can cause DIC. Okay, because again you lead to the widespread activation, okay, of your coagulation cascade, right? You make a lot of clots, so you consume a lot of coagulation factors, you consume a lot of platelets, and then you bleed. All right, so that's what DIC is. So that's placental abruption. Also in the obstetric mnemonic, right? Consider amniotic fluid. So if amniotic fluid, right, leaks in into the mother's blood, into the mother's bloodstream, then why is that bad? Because amniotic fluid also contains tissue factor and mucin. Both stimulate clots to form, right? So if you have a lot of tissue factor, again, we've already gone through this, but a lot of tissue factor can activate can activate factor 7, right? And both 3 and 7 is part of your extrinsic pathway, right, of your coagulation cascade. So then a lot of tissue factor can activate factor 7, which can activate factor 10. You carry out your coagulation cascade, and then you make fibrin, right, which will help stabilize clots. So again, you're forming a lot of clots. So so that's one. And then of course, retained dead fetus syndrome can also lead to DIC, right? So when the fetus dies, right, in utero, and it's not expelled, right, for let's say for greater than 4 weeks. Okay, for example, so when the fetus dies in utero, right, and is not expelled, then the dead fetus, right, can start to break down. Okay, so if it breaks down and necrosis occurs, right, that fetal tissue, right, the necrotic fetal tissue can release tissue factor, a lot of it. Okay, and if that goes into the mother's bloodstream, then that's going to lead to widespread activation of the coagulation cascade. All right, remember, you get the activation of the coagulation cascade leads to the formation of fibrin, which will help form that fibrin mesh and stabilize the clots. Okay, and remember, part of this coagulation cascade is also thrombin, right? Remember, thrombin can help activate platelets and lead to platelet aggregation, right? Which again help in the formation of multiple clots, especially in small blood vessels. All right. So that's obstetric, okay? Now let's go to the P in the stop making new thrombi mnemonic, okay? So P stands for pancreatitis. So if you have severe pancreatitis, right, you can have certain proteolytic enzymes, right? Because remember, your pancreas releases enzymes into your intestines, right, to digest food. So if you have pancreatitis, inflammation of your pancreas, what that leads to, and we'll talk about this in our GI playlist, but in pancreatitis, you can get activation of your enzymes, okay, inside your pancreas. You can start auto-digesting your pancreas. But some of those enzymes can also leak out into your bloodstream. And if it does, then of course, if it's proteolytic enzymes, it can lead to endothelial damage. And we know endothelial damage leads to the activation of your coagulation cascade. All right, because remember, damaged endothelium, as we saw from the trauma, right? As we saw from when we discussed trauma, if your endothelial is damaged, endothelial lining damage, it can express and release tissue factor, which can lead to the activation of the coagulation cascade. Okay. And of course, if you activate the coagulation cascade, you make a lot of fibrin to stabilize your platelet plug, and you make a lot of thrombin, right, which is part of that common pathway, part of your coagulation cascade. And thrombin can also help stimulate platelet aggregation, activate platelets. And remember, thrombin also activates factor 13 to actually cross-link the fibrin. Okay. So that's pancreatitis. All right. Okay, so now that fulfills the stop part of the stop making new thrombi mnemonic, right? So now let's go to the making, right? The making starts with an M, and that M will stand for malignancy. All right. So remember, in acute promyelocytic leukemia, and we'll talk about this when we talk about white blood cell in our white blood cell cancer playlist, right? But acute promyelocytic leukemia or APL, remember it's caused by a 1517 translocation which leads to the PML-RARA fusion gene, right? But the main thing to remember is in APL, you make a lot of promyelocytes, okay? Because remember your myeloid stem cell lineage, right? It's supposed to eventually lead to granulocyte formation, right? So remember, let's see, let's do it real quick right here. So remember, we have our myeloid stem cell, right? That can differentiate into a myeloblast, right, which will eventually go and make your granulocytes, right? So remember, your myeloblasts can then differentiate into your myelocytes, right, eventually. So first it would actually be your promyelocytes, and then your promyelocytes can differentiate into myelocytes. And then remember your myelocytes, after your myelocytes, we get your metamyelocytes, And then from your metamyelocytes, eventually we go to a mature granulocyte, right? So your granulocytes are your neutrophils, eosinophils, and basophils, right? So we go to a band cell first, and then we get your granulocytes, right? So if we go from a myeloid stem cell to myeloblast to promyelocyte, myelocyte, metamyelocyte, then eventually to your granulocytes, where does APL come into play, right? Acute promyelocytic leukemia. So what happens is the second you get to the promyelocyte stage, you stop differentiating and you start accumulating a lot of promyelocytes, right? That's what happens in APL. Now, the problem with this is all of these promyelocytes, they contain a lot of myeloperoxidase, right? Remember, a lot of myeloperoxidase, what makes up the hour rods that we're familiar with in APL? It's the myeloperoxidase, right? So, but the problem with this is that you get a lot of tissue factor release. Okay, so remember, in APL, right, you have a PML-RARA fusion gene, okay, due to a 15-17 translocation. Because of this fusion gene, you develop abnormal amounts of promyelocytes, okay, because of that fusion gene, the PML-RARA fusion gene, and the 15-17 translocation, you stop differentiating past promyelocytes, and you just start accumulating a lot of promyelocytes, okay? Remember, all these promyelocytes have hour rods in them, and these hour rods are made up of myeloperoxidase enzyme, right? But they're made up of other things also. Okay, so we should know that. So the hour rods that are in these promyelocytes, right, are made up of myeloperoxidase, tissue factor, right, and then other enzymes. So we'll just say enzymes. So if these hour rods are made up of myeloperoxidase, tissue factor, and enzymes, and if you're accumulating, right, way too many promyelocytes, those promyelocytes will die, right? So when these promyelocytes die, they release all of these contents. One of those contents being tissue factor. So if you're releasing a ton of tissue factor, then of course, again, it's going to lead to the activation of the extrinsic pathway and then activation of eventually fibrin, right? Your fibrin clot formation, widespread fibrin clot formation. Okay, so again, you're using platelets and you're using clotting factors. Therefore, you're going to cause bleeding, which is what you see in disseminated intravascular coagulation, or DIC. Okay, so that's how APL does it. So that's so we're still on malignancy, right? So APL, but also adenocarcinomas, right? Because they have glandular tissue too. So it's important to know that also. But how do adenocarcinomas lead to DIC, right? How can they lead to DIC? Is because these tumors can secrete tissue factor. Okay, it's all about the tissue factor. And again, we know that's going to activate your coagulation cascade and make widespread fibrin clot formation. Okay, so that's malignancy. So we're done with stop making, right? Part of the mnemonic. Now let's cover the new part. So we're at stop making new. Okay, so new starts with an N, and for to represent N, we have nephrotic syndrome. Okay, so remember nephrotic syndrome, right? You have proteinuria greater than 3.5 grams a day. Okay, and part of the protein that's present in your urine is antithrombin 3, right? So remember, we part of the protein that's present in your urine is albumin, antithrombin 3, and immunoglobulins. Okay, so antithrombin 3, remember, inhibits factors 2 and 10 mainly, right? So if antithrombin 3 inhibits factors 2 and 10, but you're peeing out a lot of antithrombin 3, so now you're procoagulant, right? You're prothrombotic now because you can't inhibit coagulation factors anymore, especially factors 2 and 10. So that means if you're more prothrombotic, you have an increased chance of activating the coagulation cascade more than usual, leading to widespread fibrin clot formation, consumption of platelets, consumption of clotting factors, DIC. Okay, so that's one way. In terms of nephrotic syndrome. And then again, remember nephrotic syndrome, you're peeing out albumin, so you have albuminemia. All right, hypoalbuminemia. And remember, what does albumin do in your bloodstream? It maintains the oncotic pressure, right? So if you have albumin in your bloodstream, right, it maintains oncotic pressure, meaning it doesn't let a lot of fluid leak out into your interstitial space. But if you're peeing out a lot of albumin, you no longer have much albumin in your blood. So then you can't maintain oncotic pressure as well, and a lot of fluid starts leaking out, right, into your interstitial space. And if fluid leaks out into your interstitial space, then by definition, you increase the thickness of your blood or the viscosity of your blood. And we know increased viscosity of your blood increases clotting. The more you clot, the more coagulation factors you consume, the more platelets you consume, and the more chance you have of bleeding, which is what DIC is, right? So now let's go to the last part of the mnemonic, which is thrombi. So we covered stop making new, and now let's cover the thrombi part of the mnemonic. Thrombi starts with a T, so it's going to represent transfusion reactions. All right. So if you do if one undergoes transfusion, right? So you're giving blood from one person to another, and if it's, of course, not the right blood type, then this can lead to DIC, right? Because you can get antibodies that bind to the antigen of the transfused blood cell, red blood cell, right? So if, let's say someone's type A blood and you gave them type B blood, then the person who had type A blood would have type B antibodies, and those type B antibodies would bind to the B antigen, right? Of the type B blood patient. And then you would, of course, get a transfusion reaction, right? Where your immune system basically attacks the incoming red blood cells. So when your antibodies bind to the incoming red blood cells, right, that can activate the complement system, and then you can get hemolysis of red blood cells in your bloodstream. And then, of course, we know that can lead to DIC. All right. So remember, in in a transfusion reaction, let's say, right, you gave a type A blood type patient type B blood. Okay. So if you're type A blood, you're going to have IgM antibodies against type B against the B antigen. Okay. So if you give type B blood to this person, of course, these antibodies will start binding the B antigen. And then we know after antibodies bind to antigens, it attracts the complement system. So you get the activation of the complement system. We know that leads to activation of the membrane attack complex, which then lyses your red blood cells, right? So you can get a lot of intravascular hemolysis. Now, what's inside your red blood cells? Hemoglobin. So if you get massive release of hemoglobin, free hemoglobin, right, inside your bloodstream, on top of that, right, because of this massive immune response, we know that can lead to a lot of inflammation and cytokine release. So if you have tons of like cytokines like TNF alpha, IL-1, IL-6 being released, we know that can lead to fever, right, shock, because remember, inflammation and cytokines like this in general can lead to widespread vasodilation, which can lead to shock because it's going to tank your blood pressure, right? So not only are you getting fever and shock-like symptoms, hypotension, right? But remember, free hemoglobin, this massive release of free hemoglobin due to massive intravascular hemolysis, is directly damaging to your endothelium. Remember, when your endothelium is damaged, right? Endothelium is damaged. What does it release? Factor 3, tissue factor, thromboplastin, right? And then from there, we know what happens. We get activation of the extrinsic pathway, leads to the formation of thrombin and fibrin, right? So you get widespread fibrin clot formation. And of course, thrombin can help activate platelets too and platelet aggregation, right? And so you consume platelets, consume clotting factors to make a bunch of clots. But because you're consuming platelets, consuming clotting factors, that leads to bleeding, okay? Which is DIC. So that's intravascular hemolysis. All right. So that's due to transfusion reactions. All right. So we got the mnemonic now, right? So stop making new thrombi. All right. So we have sepsis, trauma, obstetric, right? Including what? This has multiple, remember, placental abruption, and it also has amniotic fluid release into the mother's circulation, right? And it's all based on factor 3, which is tissue factor, thromboplastin, right? So, and then we have pancreatitis, and then we have our making new thrombi mnemonic, right? So we have the M part of the mnemonic, which stands for malignancy, right? And what malignancies do we talk about? Adenocarcinoma, right? Because these tumor cells can release tissue factor, right? And then we talked about acute promyelocytic leukemia, where you have the PML RARA fusion gene, right? Due to the 1517 translocation, leads to the abnormal proliferation of promyelocytes who contain our rods, right? Made up of myeloperoxidase and tissue factor and other enzymes. One of them, but the main part being the fact that the outer rods are made up of tissue factor, right? And if those promyelocytes die, right, then that leads to widespread really or that leads to massive release of tissue factor, leading to widespread coagulation cascade activation. All right, which leads to widespread fibrin clot formation. Okay, so that's the M part of mnemonic. And then remember the T that we just discussed, right? Which stands for transfusion reactions, right? If you give the wrong blood type to a patient, then you're going to have massive immune response, hypotension, shock, fever, and intravascular hemolysis, free hemoglobin release, leading to endothelial damage, leading to expression of tissue factor, leading to widespread coagulation cascade activation. Okay, and then remember the N in the stop making new thrombi mnemonic stands for nephrotic syndrome, right? So remember nephrotic syndrome, you're peeing out antithrombin 3, which leads to you being in a more prothrombotic state because antithrombin 3 mainly inhibits factors 2 and 10. So if you can't inhibit clotting factors anymore, then you're going to be in a prothrombotic state, which puts you at an increased risk of clotting, right? And then, of course, you're also peeing out, not only are you peeing out antithrombin 3, but you're also peeing out albumin. If you have low albumin in your bloodstream, you're going to have a lot of fluid leaking out and going into your interstitial space. If you have a lot of watery fluid leaking out of your bloodstream, your blood is going to get more viscous. Increased viscosity of blood, we know, increases the formation of clots, right? So that's basically it, okay? Sepsis, trauma, obstetric, which includes placental abruption, remember that, and retained dead fetus syndrome, and amniotic fluid leaking into the mother's circulation. Then pancreatitis, and we have malignancy, which includes APL and adenocarcinoma, nephrotic syndrome, and transfusion reactions, okay? So those are the main causes that we should remember. All right, so let's go and talk about the main thing, which is lab findings. All right, so for DIC, the lab findings should make sense because remember, you're getting widespread clot formation, especially in small blood vessels, also like your capillaries. And if you're getting a lot of microthrombi formation, remember, when red blood cells go across these microthrombi, right, that contain fibrin. Okay, remember, you're getting coagulation cascade activation. What's the product of that? Fibrin formation. What can fibrin do if red blood cells come across it, right? Especially in these microthrombi and small blood vessels, when red blood cells come across fibrin, they get sheared into cystocytes or helmet cells that you'll see on blood smear. Okay, and what is that called? Microangiopathic. Okay, so in small blood vessels, like your capillaries, for example, hemolytic, because you're lysing your red blood cells, anemia, right? Because you're again lysing red blood cells. So you get microangiopathic hemolytic anemia and DIC. So you get schistocytes. And then everything else also makes sense, right? Because if you're getting widespread clot activation, widespread clot formation, well, what do you need to form clots? Platelets. So you're forming a bunch of clots, right? So you're going to use up your platelets. So you're going to see thrombocytopenia. You're using up all of your clotting factors. So you're going to see your PTT elevated and your PT elevated because you're using all your clotting factors, factors involved in the intrinsic and extrinsic pathway. Remember, PTT measures intrinsic pathway plus common pathway, and PT measures, monitors, right, extrinsic pathway and common pathway. Okay, you're using all your clotting factors up. So your PTT and PT is going to be elevated. And remember, what's the end result of widespread activation of coagulation cascade? You eventually get fibrinogen to fibrin conversion. So if you're getting a lot of activation of coagulation cascade, you're getting a lot of conversion from fibrinogen to fibrin. So then that would mean fibrinogen levels will start to go down. And that's what you see in DIC. Okay? Remember, you're forming a lot of fibrin clots, right? What happens if you break down fibrin clots? Well, what's the byproduct of breaking down fibrin? D-dimer, okay? So your D-dimer will be elevated in DIC, all right? So those are the main lab findings, okay? And I hope these lab findings make sense. So now we can talk about the treatment, right? So when we talk about treatment, like we should understand um, basic things about like what you can give, right? So there's four main things you can give in terms of treatment in DIC. All right. So what I should say is first let's understand the four main blood product types that you can give. Okay. So first thing, right, we should talk about is packed red blood cells. All right. So what are packed red blood cells, right? Well, they're in the name. So this is mainly for acute blood loss or severe anemia, right? So this is basically concentrated red blood cells, okay? Concentrated red blood cells meant for giving it to patients who have acute blood loss or severe anemia, right? They're packed red blood cells, concentrated red blood cells. So you can increase your net hemoglobin in your bloodstream. Therefore, you can increase oxygen delivery to tissues. Okay. Another blood product, right, that you can give or blood product type is fresh frozen plasma, right, or commonly seen as FFP. So why is fresh frozen plasma good? Well, fresh frozen plasma the main use for that is to replace your clotting factors, right? So so a good place to use this would be DIC, right? Which is what we're discussing. So why, well, what is in fresh frozen plasma, right? So you have all your clotting factors here. So you have your like factors two, right? Factor five. I'll just write in normal numbers so it's easier. Factor five, factor seven, factor nine, 10, right? 11, 12, right? So all your clotting factors basically. And don't forget about protein C and S, right? Which are anticoagulant. So protein C and S, okay? And fresh frozen plasma can also have fibrinogen in it. But the main point of FFP is to replace clotting factors. So why would you give this, right? In what conditions would you give this? In conditions that cause decreased clotting factors like DIC, where you're consuming a lot of clotting factors, liver failure. Remember your liver makes factors 2, 7, 9, 10 CNS. So if your liver's failing, you can't make factors 2, 7, 9 CNS. So then you would, so then that would be an indication for FFP, right? To restore clotting factors. What if you gave way too much warfarin? What does warfarin do? Inhibits vitamin K epoxide reductase, right? Remember, you need vitamin K, right, for your liver, for your factors 2, 7, 9, and 10 to properly function and to participate in the coagulation cascade. But if you gave too much warfarin, right, you inhibit the crap out of vitamin K epoxide reductase, right, which means you can't have factors 2, 7, 9, and 10 functioning properly, right? Because remember, right, we went over this in a previous video, but remember vitamin K epoxide reductase does what? It reduces vitamin K. So you get reduced form of vitamin K. And you need the reduced form for the enzyme. Remember this enzyme, gamma glutamyl carboxylase, right? You need the reduced form of vitamin K for this enzyme to work. And what does this enzyme do? It carboxylates glutamic acid residues of certain factors, like factors 2, 7, 9, and 10 that your liver makes. Then, only when these factors are carboxylated, then it can bind to calcium, and then only then it can get activated and participate in the coagulation cascade. So we see that you need vitamin K in order to have functional factors 2, 7, 9, and 10. So if you have like overdose of warfarin, then you inhibit vitamin K epoxide reductase way too much to the point where you don't have any reduced vitamin K. So that means you won't have functional factors 2, 7, 9, and 10, which means you have a deficiency in these clotting factors. So that would be another indication for fresh frozen plasma where you have factors 2, 5, 7, 9, 10, 11, and 12. Okay. So that's one thing. And then of course, so just remember those main three things, right? DIC, liver failure, and then warfarin overdose. Okay, like if you have to reverse the warfarin overdose in terms of replacing the clotting factors, um, fresh frozen plasma is good because it replaces those clotting factors that too much warfarin inhibits, right? So warfarin overdose is another indication too. All right, so that's that. And then, of course, if you give clotting factors to a person that doesn't have clotting factors, this can help correct their PT and PTT, right? So that should make sense too. Another blood product that we should be familiar with is cryoprecipitate. Okay. Now, cryoprecipitate is important because it contains important things like what? Like fibrinogen, factor 8, factor 13, and von Willebrand factor. Okay. So why would you give cryoprecipitate if you're deficient in fibrinogen? Okay. Or if you're deficient in von Willebrand factor. All right. So if you're deficient von Willebrand factor, where do we see that? Von Willebrand disease, right? So cryoprecipitate could be a consideration in von Willebrand disease. What if you have DIC and you're consuming and you have a lot of fibrinogen to fibrin conversion and very low fibrinogen levels? Again, that would be you would consider giving cryoprecipitate. All right. So those are those are indications there, right? For cryoprecipitate. And the last thing is just plain platelets, right? And of course, when would you give platelets if you're low in platelets? So if you're severely low in platelets, you can consider giving platelets uh so you can help clot blood, right? So you can help form clots, proper clots, because you need platelets to form that weak platelet plug, as we talked about in primary hemostasis. All right. So the reason to talk about all this was so we can understand the treatment for DIC. So again, if you're using a lot of clotting factors, who restores clotting factors? Fresh frozen plasma, right? It has clotting factors like 2, 5, 7, 9, 10, 11, 12, right? So that can help correct your PT and PTT. You can give platelet transfusions, right? Why? Because you're using platelets to form what? Clots in DIC. So if you have severe thrombocytopenia, you can consider platelet transfusions. And remember, in DIC, you have very low fibrinogen levels. Okay, so you can consider giving cryoprecipitate because that contains factors 8, 13, von Willebrand factor, and fibrinogen. All right, and of course, if you have, for example, if the cause of DIC, right, involves loss of red blood cells or hemolysis, things like that, you can consider packed red blood cells. Okay, so, but remember, DIC is caused by something, right? Whether that's sepsis, trauma, or an obstetric cause, pancreatitis, right? Or whether that's malignancy, right? Nephrotic syndrome, or transfusion reaction, right? There's a cause to it. So first, instead of just focusing on giving these, right? You want to focus on treating the underlying cause first, then consider giving these based on the lab values. All right. So if 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 one has bleeding dominant DIC, right, which means we're consuming clotting factors, consuming platelets, and they're bleeding a lot, okay, because of the of decreased platelet count and decreased clotting factors, right? Then that's when transfusions will be most useful, right? To give things like fresh frozen plasma and to give things like platelets, okay, to help them start clotting so they don't bleed a lot. But what if they have thrombosis dominant DIC, where they're forming more clots than they are bleeding? So then, that'd be something to think about. Would you consider giving more clotting factors, more platelets to someone who's in thrombosis dominant DIC, right? So you wouldn't want to give someone more clotting factors and more platelets if they're in a thrombosis dominant DIC when compared to bleeding dominant, right? Because in thrombosis dominant DIC, you're forming more clots, way more clots than usual, right, as compared to bleeding. So you wouldn't want to make them form more clots by giving them more clotting factors and more platelets, right? So that's just something to differentiate and think about when talking about DIC. All right. So I know this video is probably way too long. I hope it wasn't too confusing. I hope this made a little bit of sense, right? And thank you guys for watching and see you guys in my future videos.